Hi, it's Andrew Merritt again. Now we're going to move on. We've talked about the anatomy, the mechanics of the knee, and how an ACL tears. Now we're going to talk about the actual ACL tear and the complex other injuries that can happen. We will get to reconstruction and surgery. Again, looking at the model, ACL tear in the center, now we know how the knee injury happens by pivoting of the knee. Now, there's a lot of other structures in the knee that are important to look at. The MRI does a great job at viewing most of these as well as the examination. So a few of them that we're going to end up talking about is the meniscus. So there's a meniscus on the inner side of the knee, a meniscus on the outer side of the knee. The cartilage that lines the ends of the joint, what's shown in blue here, it's on the tibia as well as on the femur. The cartilage is ultimately the kind of the important stuff. We want a stable knee so that it doesn't buckle under us, but part of that reason is because if we keep buckling, that cartilage is going to start to wear. Those are people that end up having cartilage injuries that lead to arthritis and things like that in the future. So we'll talk about the meniscus. We'll talk about some cartilage injuries as well that happen with the ACL, as well as other ligament tears, specifically the MCL. So just to show you that, because we'll come back to it, but as the knee pivots on the outer side of the knee, we can actually stretch, and you can see, I think, how that starts to stretch the MCL. So that combination of things can happen where it pivots, and that doesn't kind of release all of the force through the knee, so it keeps going, and then we actually stretch the MCL along with it. Now, the pivoting injury to the meniscus happens because of that shift as well. So we'll revisit all of that in a second, but first talking about the ACL. So we talked about, again, just to rehash, the ACL, the pivoting motion that causes that rotational force, causing that ACL to tear, what we call the dynamic valgus. So what's the clinical presentation? So a lot of times the young athlete will come in and say, it's usually non-contact. So they plant, they pivot, and it happens to themselves. Non-contact, someone didn't hit them. They came down from a rebound. Maybe their ankle rolled under them. They went up for a volleyball block, but they had to shift to where they were at. So they landed not square, not the axial load. So they got the shear rotational load by landing sideways. And they'll generally they'll say, they felt their knee buckle. Often they'll hear a pop, and then they'll have swelling. So in general, so these are important to get looked at. A lot of these get ignored, and it's really tough to treat if these have been ignored for a while. But essentially, if we have a young athlete with a pivoting injury that then has swelling in their knee, it's something like 80% chance that they have an ACL tear. So we have to be looking for this. Other things could be patellar dislocation, things like that, but young athlete, land, non-contact, pivoting injury, subsequently swells, get this evaluated. A knee that swells is a sign that there is an injury. Those should be evaluated. We have an urgent care for this exact reason. We can see you in clinic. You should be able to get this evaluated pretty quickly. And if you just get the answer of, oh, just let it calm down, everything's fine, but the knee is swollen in a young athlete, that is not the right answer. Knee swelling, if you have a big swelling of the knee the night of or the overnight from an injury to the knee, do not give up on getting that evaluated. Too many of these are just ignored, and it can lead to further problems. So initial treatment is to ice the knee. Crutches, if you need it, they'll probably give you a brace if you go to the urgent care. Generally, though, we want to get the knee moving. Once it's comfortable, start working on range of motion. Once we get the diagnosis, and this is why getting an MRI early is helpful, we know exactly what we are treating. We want to know what the extent of the injury is, because the faster we get rehabbing this knee, everything gets better. The less the quad shuts down, the faster we're able to weight bear, the faster we're able to get into surgery to fix this. So once we know that someone has an ACL tear, we'll get them into PT. That gets the knee moving, getting their quad, I misspelled swelling, quad activation, and get the swelling down. Those are the critical hallmarks of early recovery. Get the knee moving, get walking on it, get it going. Because again, if we just have an ACL tear, this is one of a lot of structures in the knee. The rest of the knee generally are not injured most of the time. And even if there are injuries to the MCL, injury to the meniscus, all the time. We want to get it moving, but that's why getting an MRI so we know exactly what we're dealing with is helpful. Usually weight bearing, I should have checked this, misspelled that again, and range of motion are both critical prior to getting to surgery. So getting to surgery is, we need a full range of motion knee, swelling down, quad activating. That's what we're waiting for after an injury if we're going to surgery. So an ACL tear, we've seen multiple times what it looks like when it's intact. They can come in different varieties. Some where we still see the fibers intact, but the ACL tear happened more what we call in situ tearing. So sort of like a stretch. Think of like an old bungee cord that got stretched out too much. Sometimes these can be treated conservatively. A lot of times, actually, especially in older athletes, they heal enough to give you good stability. But at least then getting an MRI, we know what we're dealing with. We can be proactive with the physical therapy. These are the type that are often good for a repair versus a reconstruction, where you still have the ACL nicely attached to the tibia, but it's pulled off. There's not a continuous ligament up to the femur. Then we get to the more substantial ones. These are the young athletes, explosive injuries, pretty much all the time. Reconstruction is the route forward. Wispy little tissue left, nothing connecting up top here, or just straight torn right in the middle. No ACL bridging the gap at all. All of this is MRI is helpful to evaluate which one of these we have so that we can address it appropriately. Again, the knee shifts and that pivot injury. If we look at the model again, that happens when the outer side of the femur rotates back and hits the back of the tibia. We can almost always see it on the MRI. This would be sort of very basic one. The bone hasn't been impacted at all, but you can see the bruising. Then we start to, these are the additional injuries that can happen from the ACL. You can see this in this patient. It actually was so impactful, it dented the femur. That's a fracture. That's what we call a subchondral fracture, a fracture underneath the cartilage on the end of the femur, and even impacted this bone a little bit. Sometimes that can get worse as well. In really soft bone, so this is often an older athlete, sometimes an older female athlete, a little bit softer bone, it can dent in the end of the tibia. So here is normal on the left, and you can see that the edge of the outer side of the knee comes all the way back outside of this meniscus on the outer side. And here you can see how much that's been dented in right there. So that used to look all the way like that. And because this shifted and smacked that in, this is an important consideration. It's a fracture that comes along with an ACL tear. So you may get told, oh, you have a plateau fracture, a lateral plateau fracture. That's the term we use. This is what we call the plateau of the tibia, because it's like a plateau in geology. And it's a fracture because it is dented in. Now, it's not the type that we can't walk on, that we can't move. We get these knees moving still, but it influences our desire, or our sometimes the need to do an ACL, because you can just imagine there's less that this knee has to shift back to continue to feel unstable. So often these patients are the ones that feel very unstable. Even if this ACL is torn, this has to go a really far way back before you would start to feel that buckling motion again. This, it's almost off the edge just with them laying straight. So very little pivoting causes that feeling. So these are the associated bone injuries that we see with the ACL. Now, when we get to surgery, normal ACL, again, we've seen this in some of the other videos, a big healthy ligament crossing across the joint. An acute ACL tear will actually see the fibers. Think about you're towing something and the rope snaps. It would look like the end of a snapped rope. In a chronic ACL tear, so after 6 months or so, your body actually generally absorbs that. It reuses it for different purposes. It absorbs that collagen. So we will get into those knees and just see nothing crossing across the joint at all. So your body actually absorbs the fibers that aren't being used, uses them for something else, not sure what. And so we can tell a little bit the chronicity. So sometimes people come in and be like, yeah, my knee's never been right since an injury 7 years ago, but now it's really feeling unstable. What probably happened is they tore their ACL, they learned to live with it a little bit, but now there's nothing left and the knee just keeps pivoting. So sometimes this is kind of good if it happens, but it doesn't fully reconstruct an ACL, is if you have an ACL fibers, sometimes it pulls off, but the next thing right by it is the PCL. So the ACL can heal to the PCL, and it gives you some stability, not the rotational stability, but gives you some front back stability. So here's the ACL coming up. Here's the fibers that should be going up to this femur out here, and you see how it curves and actually heals to the PCL. So, you know, if there wasn't the option of surgery, it's better to do this than to just absorb it all of the way, because it gives you some stability back. And even the MRI can sometimes be called as normal. I've seen this by the radiologist where the ACL is called normal because it still looks like it's going up that direction, but it doesn't go to the wall, it goes to the PCL instead. And these you can still feel on examination, that rotation. The meniscus is a common associated injury with the ACL. We'll have whole talks on just the meniscus itself, but if we look at the MRI, now we're looking from the front of the knee. So this is the inner side of the knee. This is the outer side of the knee. So it's like you're looking at someone's right knee. Would be a right knee, since this is the outside from the front. And the meniscus are these little, this is what meniscus looks like in cross section. Again, looking at the model real fast, when you look at the top of them, they're these little hoop structures. And essentially what the meniscus does is it gives a better connection between the curved end of the femur with the flat top of the tibia. So anytime that curved meets flat, it's nice to have a little bit of a soft structure to make a dish. And you can see how that makes the dish here. Well, if you look at it in cross section, it's big on the outside and narrows thin to the inside to create that dish, that cup that holds the end of the femur. So this is what it looks like in cross section. On the side view, this is what we've been looking at. This is the same view. This is the front of the knee, back of the knee, front of the knee, back of the knee. Same cross-sectional structure to the meniscus. So we're going to be looking very carefully at these to see if there's tears. A normal meniscus at the time of surgery. Here's looking at the inner one. This is the end of the femur, the top of the tibia here, the meniscus going around. It should be a continuous hoop. Should look boring. There shouldn't be some torn and flapping around, and you can see how this makes that nice dish. Here's the outer side of the knee, what we call the lateral meniscus, again attached in the back, attached in the front, and just very continuous. So a tear can come in a lot of different forms. Meniscus is one of the most confusing things that we talk about. And so a common or somewhat common one with an ACL tear is what we call a bucket handle tear. That's where it completely detaches, and that meniscus can now flip to the front of the knee, to the back of the knee, or from the outer side of the knee to the inner side of the knee, sort of like the handle of a bucket. So if we go back and we look at the meniscus, it should be stuck to the back. You should not ever see it in front of the end of the femur here. Here you see the meniscus in front of the end of the femur here. That means that it's unstable. It's completely pulled off of the back wall. This is absolutely a critical injury to fix for someone. And the way that we do that is that we suture it. You can see all these sutures holding it back to the wall to get it to heal. We fix the ACL at the same time because we don't want the knee to continue to shift and put stress on our repair. But this is a type of a meniscus tear that is repaired. A more complicated type is a meniscus tear that goes through the meniscus, what we call radially. So it detaches the hoop. In the bucket handle tear, the hoop stayed in place. It just is not attached to the wall. In this situation, it actually cuts across the hoop. And the way this, if we look at the model, it can sometimes happen is on that it's the outer meniscus. So we're looking at the outer side of the knee. And as that knee shifts, it sort of snow plows through that meniscus, and that meniscus stays attached in the far back, stays attached over here, but tears through it. This is if you're picking from a menu of meniscus tears, this is not the one that you're wanting to pick. So you can see the meniscus come and end, the meniscus start where it should be attached and come up this way. So those two ends should need to be knitted together. So what we do is put some stitches to what we call rip stop stitches. So stitches that go through the bulk of the meniscus to allow those other sutures that cross it to not pull out, because they'll want to just pull out from the meniscus tissue. So put a couple ripstop stitches and then pull the meniscus apart. These would be one of the types that you would have to not be weight bearing after surgery. And then a lot of times we just have, especially in an older athlete, just kind of the meniscus looks a little torn up. A lot of just fraying tissue, kind of the road rash type tissue instead of a slice, more like a road rash. So here you see still good cartilage, but all this is just junky sort of meniscus tissue. You can imagine this is not the type that you're stitching stuff up. All of this stuff is small. There's no blood supply. It's avascular. So what we do is we just go and clean up, leave all the good meniscus in place. That's the most important part here, is leave anything good, but clear up all this stuff that's flipping around the knee. And here is after. The meniscus here, yes, there's some missing tissue here, but still has the meniscus hoop intact, still has the majority of the meniscus, but you can see there's no option like stitching up. So sometimes we just have to clean up some of that junky tissue so it stops bumping around in the knee. MCL tears, for the reasons I discussed. If the knee pivots, but the MCL gets stretched, you can have an MCL injury. So here, these are both looking at the front of the knee. The MCL is on this inner side of the knee here. It supports the stability of the femur up here to the tibia. Attaches in two spots here, and actually is intimately involved with this meniscus as well. Usually, and better, is the tear off the top part here. So you can see here on the right side, this MCL still looks good until it gets up to here, and all that white and irritated tissue is the MCL pulled off right there. If we look at surgery, if that MCL, generally they heal. Generally, we just need a little time. They scar down nicely, actually really good. This is incredibly common injury in the knee. Isolated, just an MCL injury, almost always heal, pretty universal. If they don't, at the time of surgery, what you can see is looking at the inner side of the knee joint, if we stress the knee and pull it open, the end of the femur to the tibia in a normal MCL, you can't see that meniscus in the back. This distance is not that high. If they have a torn MCL, you can see almost that whole back of the meniscus. Much higher distance here between the end of the femur. That's what an MCL tear would look like at the time of an ACL surgery if it had not healed. But generally what we do is we allow 6 weeks. Almost always they heal, especially if they're off the top. But then we get stress x-rays to verify. This would be one that doesn't heal. You can see my hand up top here, and I'm actually pulling the knee. I'm holding here and pulling the tibia this way to show the distance here. And this is quite a large gap. So this would be consistent with an MCL that has not healed enough that we can ignore that. We also have some cartilage injury. So stop now if you don't want to see any graphic pictures, okay? So we're going to be looking at surgical pictures. It shows an open knee to see the cartilage injury. So fast forward or stop if that's not what you want to see. But sometimes when you have that pivoting injury, you can actually injure the cartilage. All right. So I'm going ahead if you're still with us here. So this is looking at a knee from the front. So this is all that white, healthy, great cartilage. And you see this injury to the cartilage through here. My red pen's not really showing up. So just, you can see that right there. So otherwise healthy knee, but just this one traumatic scrape injury of the cartilage he had actually a recurrence, so a second ACL tear in this situation. Since all the cartilage around looks really good, what we can do is identify the edges of that and core out a little space to put a graft. We get a cadaver graft with fresh cartilage. So this is a patient that has passed away, but they have pristine cartilage. It's never frozen or anything like that, so all the cells are alive. We have to order these ahead of time. It takes about 2-3 months to get, and then we have about 7 days to put it in. And it's all shaped. The geometry, we send the MRI, we make measurements. This is all shaped width-wise, length-wise, everything and the curvature to the patient that is injured. We find that same spot, take a graft. The graft has bone because bone's what heals. Cartilage doesn't heal, so we need to transplant the bone along with the cartilage to get the cartilage to stay alive. And then we put that into the knee joint. So now there's nice smooth cartilage back into the knee joint. So that is some of the injuries that come along with ACL tears. The ACL is obviously one part of a complex structure of the knee joint. These are the things that why we want to get an MRI early, why you need to see a surgeon that is looking at this stuff, not just the risk factors we talked about in the previous videos, but other injuries, and then be motivated to fix them. So I hope this was educational. We'll talk about the actual surgical reconstruction portion next. And as always, let me know if I can help in any way. Talk to you later. Thanks.